Hello students, I am Dr. Kathiralagan Stalin, your orthopedic faculty in ADrPlexus. In this session, we will be doing or answering all the NEET 2024 recalls question from orthopedics. So the first question goes like this. Patient presented with a mass which showed a small blue cell eosinophilic tumor. So the question is small round blue cell tumor and what are the translocation. They have given some 4 options. We had like 3 options on hand and the 4th option I'm not sure. Okay, so this question is from our workbook page number 143 and that's the screenshot of the page number 143 when I was taking the video session. See how we started Ewing sarcoma. The first word we used to describe Ewing sarcoma was a small blue cell tumor. That is the word we used to describe Ewing sarcoma. And also if you look into like point number 5, we have mentioned very clearly translocation 1122. So that was an option. So that should be the right answer. They have given the histological picture and the histological picture shows a classical eosinophilic small blue cell tumor. So this should be an easy question for person who had listened to our workbook based video session. Okay. Coming on to the second question, patient with a road traffic accident came to ED with a complaints of back pain, no neurological deficit. The X-ray of the spine was given. What is the diagnosis? So if you look into the X-ray shows like a transverse fracture line which is going through and through the vertebral body and also the processes, and it's like a transverse pattern. Can you see the whole transverse pattern in the vertebra? And that exactly matches our page number 72 in the workbook, and that's the screenshot from my class. And chance fracture, if you see chance fracture, the chance fracture also shows the similar transverse pattern. So this is nothing but a chance fracture or seat belt injury. So what happens in a seat belt injury? So whenever there is a collision, you try to bend forward, which means a flexion, and because of the seat belt it will distract you. So there is a flexion distraction injury, and during my class I said that is the most common mode of injury to the vertebra, flexion distraction injury. And while writing the notes as well, I have written a chance fracture, which is a transverse fracture like that, is also called as a jackknife injury. It is also called as a seat belt injury, and this is happening because of a flexion distraction injury. Usually there is no neurological deficit, but if it is unstable then you got to fix it, otherwise you don't need to fix it most commonly. Okay, so this was from our workbook again. So hope you guys answered that question right. The next question, again 18-year-old boy, fever, elevated ECR, pain and shiny skin. See, the thing is, when they have given this X-ray, many people said that, sir, although the tumor was shown in the diaphyseal region, we could see a classical sunburst appearance. We can see a classical Codman appearance. In that case, it has to be an osteosarcoma. So something like this they could have given, right? I'm not sure about the picture because you guys have to comment whether this kind of picture was given or is it anything different. But remember, this sobable appearance, sunburst appearance, this Codman, not everything is so specific, guys. What does Codman triangle and sunburst appearance or the onion peel appearance? All are saying it is an interrupted periosteal reaction. That is what it conveys, right? And even in my workbook, I would have said, if it is an interrupted periosteal reaction, it indicates malignancy. I didn't say it indicates osteosarcoma. We say it indicates malignancy. So sunburst appearance, Codman triangle and onion peel can happen in malignant condition. That's what we mean while explaining the tumor. And also if you see the question, 18-year-old boy, fever and elevated inflammatory markers. So this is presenting more like an osteomyelitis. Whether osteosarcoma or Ewing sarcoma, which would present more like an osteomyelitis? In my workbook in page number again 143, if you go to Ewing sarcoma, we have described that it is very commonly having the habit of presenting like osteomyelitis. That was marked during the class. It presents like an infection with pain, fever, swelling, and the differential diagnosis is osteomyelitis. And the presence of fever is considered to be one of the bad prognostic marker, because this will force us to diagnose it as an osteomyelitis and waste our precious time dealing with this kid instead of starting the actual treatment. So this is not a very good sign. It is a very bad prognostic sign. The another controversial point what other people were telling is, sir, the questions start with the word 18-year-old boy. In an 18-year-old boy, how come it is Ewing sarcoma? It has to be an osteosarcoma. Guys, again, if you had listened to my class, I would have used this word. Ewing sarcoma is the most common tumor of the first decade, most common primary bone malignancy of the first decade. But it most commonly happens in second decade than the first decade. Do you remember this distinction I was making? Although Ewing sarcoma is the most common tumor of the first decade, Ewing sarcoma most commonly happens in the second decade. But in second decade, there is a very powerful competitor who is osteosarcoma. That is the reason why the incidence of Ewing sarcoma looks to be less in second decade. But actually, if there is 100 Ewing sarcoma happening, 60 Ewing sarcoma would happen in a second decade. But in the first decade only 40 is happening, but during the first decade there are no other competitors. That is the reason why in first decade the most common tumor is Ewing sarcoma, in second decade the most common tumor is osteosarcoma, but Ewing sarcoma most commonly happens in second decade. Do you remember? This is the same points that I was repeating from my online class while I was discussing page number 143. Yes or no? Yes, we have discussed that point. So remember, please don't get confused by this age criteria. Okay, that 18-year-old boy, it cannot be an Ewing sarcoma. It can be an Ewing sarcoma. It can be an Ewing sarcoma. Then how do you really need to diagnose? When this X-ray was given to you, all you need to look is whether it is metaphyseal, diaphyseal or diaphyseal. So look, it is completely diaphyseal, which is slightly extending into the metaphysis. So this tumor, although it shows a sunburst appearance, although it can showing a Codman appearance, this involves the whole of diaphysis. In that case, it has to be marked as an Ewing sarcoma. So the answer for this question is Ewing sarcoma. Again, a question which was well discussed in our workbook. The next question, very controversial. Fracture fixation in a child, and they have given you a plate and screw, and they have asked for what is the way that the healing has happened. So whether it is through a primary callus, secondary callus, intermembrane ossification, or a creeping substitution. Guys, this question answer is from the first page of my workbook. The first page of my workbook. While discussing about bone formation, I said a bone can form through enchondral ossification, it can form through intramembranous ossification, or it can form through oppositional growth. And oppositional growth will help just in the thickness of the growth. For example, thickness of the bone. For example, a remodeling of a fracture can be because of oppositional. A person gaining the bone weight by lifting heavy weights, that can be oppositional. It just increase the thickness. But while discussing about intramembranous, we use this word. Look, primary healing of a fracture is through intermembranous ossification or intermembranous bone formation, and whenever there is a callus formation, that bone heals through enchondral ossification. Yes or no? So from this tabular column in page number 1 from my workbook makes very clear that only if there is a callus, enchondral ossification happens. If there is no callus, then it is primary healing and only intermembranous ossification would happen. Now your question is, sir, whether in this plate and screw fixation will there be callus or not? Go to the next discussion at page number 8. This is again a screenshot from page number 8. While I was discussing about the fracture healing, I used the word primary healing and secondary healing. In the word primary healing, I again marked this word. Look at this. No callus is seen. No callus is seen in primary healing. No callus is seen in primary healing. So the examiner have given you a surgical plate fixation. See, all these words were underlined in your workbook. No callus, and they have given you a surgical plate fixation. So no callus, surgical plate fixation is primary healing. So from page number 8, you should say that this is a primary healing, not primary callus. Not primary callus. It is primary healing. If it is a primary healing, what is the ossification which would happen? From page number 1, you know the ossification which would happen in a primary healing is intermembranous ossification. So the answer for this question is intermembranous ossification. Lot of online platform discuss this as primary callus. My question would then be, what do you mean by the word secondary callus? Callus is callus. So even while describing callus, they say the callus would primarily form when there is a micro movements which happens at the fracture site, which is a feature of a secondary healing. But such micro movements would not happen in a surgical plate compression fixation. So the answer for this is primary healing, and the ossification is intermembranous ossification, and the examiner wants to check your knowledge on this topic, and that's why he has raised this question. Okay, so please don't go wrong again by listening to other online platforms. So this is a very clear question, and the answer is intermembranous ossification. Okay, next, coming on to the next question. A football player, twisted knee, no bony injury, which means there is some ligament injury that they are trying to assess you on, and examiner is doing this test. What is this test? So this was the image given, or something similar to this image was given, and if you go to page number 54 of my workbook, we have given you this picture. So we have given you a picture in which the knee is at like 90 degree, and there is a picture in which the knee is at 30 degree. And if you see my arrow marks while writing in the workbook during your online class, I have said Ligament test is done with less flexion, which is just 30 degree, and anterior drawer test is done at 90 degree. So that is the screenshot from my workbook while I was discussing with you in online classes. And here in this picture you can see the knee is less flexed when compared to the anterior drawer test. So the answer for this has to be Ligament. And we also discussed Ligament is the most sensitive test, and pivot shift test is the most specific test because it assesses also the PM bundle of the ACL. Yes. So this is from page number 54 of our workbook. Coming on to this question, what type of classification used for this fracture? And students are not very sure what kind of picture was given. Okay, if it is just a lateral picture like that, as in this question, okay, if it is just a lateral picture, then it is Gartland type 3. It's a supracondylar fracture because condyles are down there and the fracture is slightly up there. So it has to be a supracondylar fracture and it is displaced posteriorly. Okay. Unless they used the word that this supracondylar the fracture fragment is unstable and moving anterior to posterior, it has to be marked as completely displaced to supracondylar, which is Gartland 3. If they used this word unstable and moves anterior to posterior, then only you can think of Gartland 4 or Gartland 5. See, Gartland 4 and 5 are too niche topic for UGs. I don't think they would have tested your knowledge on Gartland 4. Okay, if they had used this word, it is highly unstable and moving anterior to posterior, or if they have given an arrow mark in the lateral view, putting front and back in it, then you should be answering as Gartland 4. Otherwise, the answer is Gartland 3. Some people were telling me, sir, it was not a lateral picture at all, it was just an AP picture. See, if the AP picture is looking like that, which means two condyles are intact and the fracture is just above the condyle, then again it is Gartland. From the AP, you cannot say whether it is Gartland 3 or 4. In that case, it is safer to answer Gartland 3. Okay. Then, sir, what about Salter and Harris 2 and 4? See, did we discuss about Salter and Harris 2 and 4? Yes. Just after the same, you see the page number in supracondylar fracture that we were discussing, we were discussing about Gartland 1, Gartland 2 and Gartland 3, right? Just next page we were discussing about lateral condyle fracture. In lateral condyle fracture, there are two types. It can be Milch 1 and another is Milch 2, and Milch 1 is type 4 Salter, Milch 2 is type 2 Salter. Do you remember we were discussing all that? So if they have given only AP and if you are seeing a fracture pattern of this kind, then it is Milch 1, which means it is type 4 Salter and Harris. If the fracture pattern is like that, then it is Milch 2, which means medial to the trochlea. So Milch 2, and it is type 2 Salter and Harris. So I'm not sure what picture was given, but almost all the pictures were discussed in our workbook. So that is from page number 34. So that is from page number 34. Okay. Coming on to the next question. So this question, a female child fell at home, again a supracondylar fracture, AEPOP, what is the varus deformity? So this is from page number 34 and 35. If you see 35, we have shown a picture of a cubitus varus deformity of a child here. Okay, so pretty much similar to that, you are having a cubitus varus deformity. Cubitus varus deformity is most commonly seen in supracondylar fracture in a child. Okay, so that's a clear-cut picture-based question, cubitus varus, and that was discussed with picture in page number 34 and 35 of our workbook. Okay, at the 34 bottom, we were also discussing about lateral condyle fracture. Okay, where we were discussing about Milch 1, Milch 2, Salter-Harris type 2 and Salter-Harris type 4. So this question is again directly from our workbook. Coming on to the next question, what is the implant? So if you go to page number 51, to this question you will have the answer. The question asked was, they have given you this x-ray and given like a neck of femur or a basic cervical neck fracture, and you see an implant in which there is a screw there, and the screw can move inside the barrel of the implant. And what is this fixation? This is called as dynamic hip screw. So there is a screw which dynamizes itself, so it is dynamic hip screw, and this is discussed in our workbook. Okay, so in page number 51, if you see intertrochanteric fracture, the two images I have given you. So in a same patient, there was a proximal femoral nailing on one side and dynamic hip screw on other side. So this question is from page number 54 of our workbook. So that's a screenshot from our workbook discussion. And another 55-year-old female complains of back pain. What is the diagnosis? Okay, and they have given you this picture, this x-ray. Okay, so if this x-ray was given, see one x-ray or CT or MRI, in whatever it is, if one vertebra is slipping onto another vertebra, then it is called as spondylolisthesis. This slipping would have ruptured or torn or fractured pars interarticularis. Do you remember in our workbook class I was teaching you what do you mean by the word pars interarticularis, and then I was teaching you the definition that spondylolisthesis means a slippage of one vertebra over another vertebra. Because of this fracture, the Scotty dog, what you would see there, would look as though it is beheaded. So beheaded Scotty dog appearance. Yes, all this were discussed, and I have also given you a picture in our workbook page number 78, that how a vertebra would look when it slips from another vertebra. They have just taken the picture and given you as an X-ray format or CT format or MRI format, and that was an asked question. And next question, see guys, there are two questions which was related to which nerve was affected. Okay, in one session they have given one image, and in another session they have given another image. Okay, so in this image, if you see the bottom there, so that would be a sacrum, and then so L5 there, L4, L3 and L2. So between L2 and L3 there is a disc prolapse which is happening, and the most common type of disc prolapse is a paracentral disc prolapse. So whenever there is a paracentral disc prolapse happen, which nerve root is affected? So that was pretty much like a question, right? So L2, L3 is affected. From the image you can pick that, and whether L2 is affected or L3 is affected, we don't know. Okay, let's wait and answer. Okay, the next question asked in the another session was, a similar picture was given in which an L4 and the L5 disc was prolapsed. So L4, L5 disc prolapse, which nerve root is affected? And patient was given a classical finding of a sciatica pain radiating to the back of the thigh. So which nerve root is affected? In that case, go to page number 76 of our workbook, in which I have used this word. The types of disc prolapse can be a central disc prolapse, paracentral disc prolapse and far lateral disc prolapse. But paracentral disc prolapse is the most common type, and the traversing nerve root is affected. And what do you mean by the word traversing nerve root? In the same page, if you see, we have described. So whenever if you see a L4 vertebra and L5 vertebra, the nerve which is coming out between L4 and L5 vertebra is actually L4 nerve root. The nerve which is coming out from L4 and L5 vertebra, in between L4 and L5 vertebra, is L4 nerve root. But during a paracentral disc prolapse, is the impinging disc impinging into the exiting L4, or is it impinging into the nerve which is traveling through the course. Can you see? Can you see the superior nerve is escaping the disc prolapse when it is a paracentral disc prolapse? Yes or no? The superior nerve escaping the impingement from the disc, but the traversing nerve L5 is getting impinged. Do you remember this was discussed with the image? So don't go by your anatomical knowledge between L4 and L5. L4 nerve is going out, so L4 is the most common nerve to be affected there. No, because paracentral disc prolapse will not touch the L4, because L4 just goes out before the disc appears. At the level when the disc is prolapsing, the traversing, the next nerve root guy would be affected, which means L5. So if the question is asked about L4 and L5, the answer is L5. If the question is asked between L2 and L3, then the answer is L3. So this was from our workbook, page number 76. So hope now you can answer that question. L5, sciatica, and L3. Okay. So now let's go to the next question. Jones fracture. Yeah, this is not like a direct repeat from our class, but while discussing about Jones fracture, I said a base of fifth metatarsal can be a zone 1 fracture, zone 2 fracture, and zone 3 fracture. Zone 1 fracture is a peroneus brevis avulsion, which is pseudo Jones fracture. It is not a true Jones. Only if it happens at the second zone, then it is called as a true Jones fracture. And if it is happening in the zone 3, it is usually a stress fracture, which is seen in among dancers. Yes, so that is what discussed in page number 61 of our workbook. But while I was discussing about the stress fracture and the management, okay, I mentioned this word whenever there is, for example, a Jones fracture, stress fracture, a March fracture, stress fracture. So all these kind of fractures in the metatarsals needs a period of immobilization. How much, how long? So the answer is actually 6 to 8 weeks. So that was discussed separately when we were discussing about stress fracture. Okay, so although I haven't discussed exactly the word 6 to 8 weeks in Jones fracture, we have discussed about stress fracture in as a separate topic in page number 5, and where I have mentioned this word 6 to 8 weeks of immobilization is needed for a metatarsal fracture, And coming on to growth plate, when I was putting this in a workbook, several people asked like, sir, do we really need to read about all the diseases which are affecting the growth plate? And I said like there was multiple times Rickets was asked, multiple times fracture happens at which growth level asked, so it is better to read. But this time they have asked a very simple question: a longitudinal growth of bone is affected by damage to dash growth plate. What do you mean by growth plate? Epiphyseal plate. So when growth plate is affected, growth is affected. Very simple. Okay. And if they are asking next time which is the most important layer, then the answer is reserve zone. Which is the most weakest layer, then the answer is hypertrophic zone. Which layer rickets would happen? Hypertrophic or provisional calcification zone. Which layer skiffy would happen? Again hypertrophic or provisional calcification. So it's a basic question, but again discussed in page number 21 of our workbook. Coming on to this question, this is very controversial because they have given a lateral image. So students are very clear, sir, it is only a lateral image, it was not an AP. Okay, they have given only a lateral image. So with the lateral image, them explaining Gerdy tubercle fracture is highly impossible. So if this question was asked and they have given you a lateral image of either this kind or that kind, then the answers can either be an Osgood-Schlatt's disease kind of tibial tuberosity avulsion. So by anatomy you can see that would be a tibial tuberosity which is avulsed. So the answer for that question can either be a tibial tuberosity, or if they have given this, if you had gone to my workbook, I have discussed a topic called as Hoffa fracture. Because Hoffa fracture you can see in a lateral view, okay, because it is a coronal plane fracture. It is a coronal plane fracture in which at femoral condyle fractures and goes or displaced. Okay, so this can be a Hoffa fracture which they would have tried. I'm not sure what is the picture. So if that was the picture, then the answer is tibial tuberosity. If this was the picture, then the answer has to be either medial or lateral femoral condyle. Then how come this is medial or lateral femoral condyle, sir. See, lateral femoral condyle is much more longer and medial femoral condyle is much more shorter there. So in that case, so this has to be, if this was the image, then the answer has to be a medial femoral condyle. So if the image was the top, then the answer has to be tibial tuberosity. That was discussed in page 25 of our workbook. If the answer image was bottom, the answer has to be a femoral condyle, and the image was discussed in page number 51 of our workbook. Coming on to loss of thenar eminence, altered sensation. If you see how we started discussing the median injury has no supply in the axilla and arm. In forearm, it supplies all flexor except flexor carpi ulnaris and half of the FDP. And in the hand, it has lateral third of the palm and 3.5 fingers. So that is how we have discussed. Okay. And the question we are asking about whether this loss of thenar eminence is due to high median nerve palsy or low median nerve palsy. Now go here. Okay, in the image of our workbook. Okay, and median nerve injury can happen there or it can happen there. Yes, so if it is happening at the level of elbow, it is high median nerve palsy. If it is happening at the level of wrist, then it is called as low median nerve palsy. So if it is a high median nerve palsy, then it would involve an anterior interosseous nerve as well. It would be involving lot of other muscles of forearm as well. In that case, you will see lot more finding, and they would have discussed that in the question, but they restricted all the finding to just thenar eminence and altered sensation on lateral 3.5 of palmar aspect of the hand. In that case, the answer has to be a low median nerve palsy, but low median nerve palsy was not in the option, and the answer was carpal tunnel syndrome. So if this question has asked, so it is from our book page 81, and the image was discussing about high median nerve, low median nerve, what all the muscles are supplied in the forearm and what all the muscles are supplied in the hand. So the answer for this question has to be carpal tunnel syndrome. And next, there is a question about the level of amputation. So see, level of amputation, we have discussed how to cut the skin, how to cut the muscle, how to cut the nerve. Okay, and we have even discussed what is the ideal length that you should maintain: above knee amputation, below knee amputation, above elbow amputation, below elbow amputation. What is the ideal length that you need to maintain? So when this picture is given, and if you are seeing tibia, so I hope you can see tibia right on top of that, and you can see fibula just down there. Okay, so you can see tibia and down there is fibula. So when you see tibia and fibula, so it has to be a leg level transosseous cut. A leg level transosseous cut has to be called as a below knee amputation. So the answer for this question has to be a below knee amputation. Okay, the next question, we are not very sure about this question because students are saying resident fully inverts the patient foot and asks the intern to palpate the structure behind the medial malleolus. Okay, are they asking our knowledge about tarsal tunnel syndrome, which we have discussed in our workbook page number 86? If that is the case, the answer should be tibial artery, because we have discussed that what are all the content of the tarsal tunnel. There you have flexor digitorum longus, flexor hallucis longus, and the artery that you see there is a posterior tibial artery, and the nerve that you see there is a tibial nerve. So if any of this four, and they are asking you for like a vascular structure, then the answer, like feeling the pulse or something like that, then the answer has to be a posterior tibial artery. Sir, they haven't given anything about that. They were giving about two tendons rubbing or something like that. Then the answer has to be flexor digitorum longus or flexor hallucis longus, because that makes a structure called as knot of Henry. Henry's knot is there at the tarsal tunnel syndrome. Okay, under the tarsal tunnel. So that could have been the question. Or if the question itself is not medial malleolus, sir, it is lateral malleolus, then if there is a word anterior talofibular, not tibiofibular, talofibular, anterior talofibular, then that would be the answer, because you know lateral ligament injury is the most common, lateral ligament of ankle injury are the most common injury or sprain in the whole body. Which side? Lateral side. Which ligament? Anterior talofibular ligament. This we have discussed when we were discussing about ankle sprain. So if the question is about lateral malleolus, then the answer is anterior talofibular. If the question is just under medial malleolus and if the option was having tibial artery, then the answer should be tibial artery. If the option was having tibialis posterior, flexor digitorum longus, flexor hallucis longus, and they were asking you which two structure intertwine, then the answer should be either of that, flexor digitorum longus or flexor hallucis longus, because they make Henry's knot there. Or if they are asking what other tendon, then from your anatomy knowledge, you know the immediate tendon which is present just behind medial malleolus is Tom, Dick and Nervous Harry. So T for tibialis posterior. So just by changing one word, if you guys haven't given me that one word which is a clue word, I cannot answer this question. If the options were having tibial artery palpating which vascular structure, then the answer is tibial artery. The option is not at all having tibial artery, then they were asking about knots, then the answer should be flexor digitorum longus or flexor hallucis longus. If the option was which is an immediate posterior structure and the option were having tibialis posterior, then tibialis posterior. Okay. So if the question is not at all about medial malleolus, the resident was inverting, but he was asking the intern to palpate the lateral malleolus, then the structure they were looking for is anterior talofibular ligament. Clear, guys? Yes. Now, the next question. A patient can't make an OK sign. Which abnormality it is? So if you go to page number 81 of my workbook, I was discussing about nerve signs. I was discussing about nerve signs, and while discussing about the median nerve and anterior interosseous nerve, I said like this benediction sign and Kilonevin OK sign. I have even given you the image. Okay, so Kilonevin OK sign is very commonly tested. So they have given an OK sign and asked which tendon or which muscle is involved. So then the answer has to be flexor pollicis longus and flexor digitorum profundus. If either of this one is in the answer, then that has to be the answer. Okay, if both of them were given, then my preferred answer would be flexor pollicis longus. Okay, but don't choose any thenar muscles. Okay, so this is assessing anterior interosseous nerve, so the answer should either be flexor pollicis longus or flexor digitorum profundus. If both of these words were not there, in that case the examiner, the question itself is wrong, so don't worry. Next question. This was like a warning message I have told you during the class while discussing my page number 65 rickets. Okay, because you all think only nutritional rickets is the rickets, and there are several types of rickets are there, and if any time we ask about the parameter of rickets, people would always say everything is low except alkaline phosphatase. Everything is low except alkaline phosphatase and parathormone. Yeah, this question, while I was discussing page number 65 of rickets, I was telling you there is not only nutritional rickets, there were other rickets there, and you guys always restrict your diagnosis to nutritional because that is the most common type of rickets in India, and in that rickets you low calcium, low phosphate, everything is low except the parathormone and alkaline phosphatase. In any kind of rickets, alkaline phosphatase is always elevated because rickets is not a bone destroying disease. It is actually an indirect bone forming disease because of poor mineralization. So alkaline phosphatase is always elevated. So you know that while discussing, I said nutritional rickets is most common only in India. Otherwise, throughout the globe, throughout the world, the most common rickets is just phosphate deficient rickets, which is also called as a hypophosphatemic rickets because it is vitamin D resistant X-linked dominant genetic pattern disorder. This is the most common cause of rickets. We were discussing that. So this time they have assessed the windswept deformity and asked you what rickets with a biochemical parameter. So on thinking little, you can answer it is just phosphate which is deficient and the patient is having rickets. So the diagnosis is hypophosphatemic rickets. Hypophosphatemic rickets. So the last question, which I am not very sure, the question was like the patient having a bone pain and alkaline phosphatase levels are increased but calcium and phosphate levels remain normal. Which other enzyme is likely to be elevated? So among all the bone metabolic disorder that we have discussed in page number 67, I have discussed about this disease called Paget's disease, and in Paget's disease I said lysis can happen, mixed lysis and blastic stage can happen, sclerosis can happen. So with regards to bone enzyme markers, you can have bone formation markers elevated along with the bone destroying markers being elevated. So if the examiner is talking about Paget's, then if this is the exact question, then the examiner is actually talking about Paget's, and the option you should mark is bone destroying marker among this option was a trap. So both alkaline phosphatase and trap can be elevated in Paget's disease. So this question I am not very sure, but we have discussed about that. And with regards to calcium, mostly calcium levels will be normal, but sometime calcium can be increased as well, especially when there is a massive lysis happening. Okay, so all findings with regards to calcium can be there. Both bone formation and destruction markers can be there in Paget's, because it is not a one pathology, it is actually a problem of disorganized communication between osteoblast and osteoclast. So they both will secrete their enzyme, and that is why you can have both alkaline phosphatase and acid phosphatase, tartrate resistant acid phosphatase, being elevated in Paget's disease. This was from our workbook, page number 67. Guys, so this is just a quick recall questions and how our workbook would have helped you to solve all the answers of your NEET examination. If you feel any of this question is like an error, or there can be some more options that you can add, I would definitely consider that as a value, because that will help us to improvise and tell better answers to our students. So if you are feeling any differences of opinion, please feel free to comment that in the comment box, and we would be happy to listen things from you and learn things from you. Okay, thanks for all the positive response that you are giving for my class.